This is the Emergency Medical Minute. The Emergency Medical Minute is excited to announce that we are now offering AMA, PRA, Category 1 credits via online course modules. To access these and for more information, visit our website at www.emergencymedicalminute.com/CME-courses, or simply click on the link in our show notes and create an account.
So just some backstory. This was an 85-year-old patient that came in after cardiac arrest. Initial presenting rhythm in the field was V-fib. She was shocked out of that successfully and started on amiodarone. And then she presented here, hypotensive, pressure 80/50 with that EKG. So as you look at that, things that stand out are the ST elevation. So in terms of organizing yourself regarding ST elevation, you want to figure out which leads are involved, because that tells you what part of the heart is involved. And then you want to assess the height of the ST elevation, because the AHA criteria for ST elevation, sometimes people just use 1 millimeter in contiguous leads, but the criteria in V2 and V3 are more specific. Does anyone know what those are? So for women, it's 1.5 boxes. For men over 40, 2 boxes. For men over or under 40, it's 2.5 boxes for ST elevation. So here you have ST elevation. Can someone just sort of point out where you see the pattern of ST elevation and where you see some ST depression, which would be presumably reciprocal changes?
So 3.
So 3 is probably the most prominent lead. So
Depression 1.
So in terms of, and then where else?
B6.
B6. Yep. And then there's some ST elevation in V1 and V2, right? So in terms of organizing yourselves, generally the way we think of it is 2-3 AVF or inferior, V5, V6, 1 in AVL are lateral, and then V1 through sort of V4 are anteroseptal or anterior. And that tells you generally what part of the heart is involved. So this is a bit confusing, because generally if you're 2-3 AVF, the reciprocal changes are in the lateral leads, so that's consistent. So this looks like an inferior MI, but the patient also has really prominent ST elevation in V1 and V2, which would be in a different artery distribution potentially. That would be an LAD. But this patient ended up having a really significant right-sided infarct. So when you see V1 and V2 along with inferior, it ends up, that's a real clue into a right-sided infarct. And the presentation did clue us into that as well. Right-sided leads classically will show in V4R, 1 millimeter or more elevation. The reason why this was sort of significant and relevant for this patient is that when you have a right-sided infarct, those patients are exquisitely sensitive to nitrates. Patient, when they're intubated and they get on a ventilator with positive pressure ventilation, that decreases their preload, so they're really predisposed to hypotension on a ventilator, and they're very responsive to fluids as a countermeasure for preload. So this is a relevant case because you see these really prominent ST segment elevations, and it really clued us into the fact that this was a right-sided infarct, and it guided the fluid resuscitation and avoidance of nitrates prior to that patient going to the cath lab. So basically, the take home from this is when you see an EKG, among the things that you're looking for is you're looking for the size and pattern of the ST elevation, and here is a particular pattern that suggests a right-sided infarct that does make a difference in terms of the medical management. All right, does that make sense? Okay. Yeah, thanks guys.
Thank you.
Hello, EMM listeners. We are dedicated to providing you with high-quality educational content free of charge and without ads. As a nonprofit organization, we rely solely on donations. So if you enjoy our show and are able to make a one-time or recurring donation to help cover our operational costs, any amount is helpful in making this show possible. Click the link in our show notes to make a donation. Thank you.